All right. That was easy, Jenny.
Good morning. We are still getting set up. We'll get started in just a few minutes. If you've just logged on, please sign into the chat box with your name, agency, and contact information, and please be sure that you are muted. Thank you.
Next week, that's
Good morning. We'll get started in just a moment. Please sign into the chat box with your name, agency, and contact information, and please remember to remain muted.
Okay, so I'm back on track here, and it says start video. No,
Well, do you have a video?
no, me.
Oh, there you are, yes.
Okay, let's do that. Okay, well, let's start over here. So I'm Dr. David Holcomb, Regional Medical Director for the Office of Public Health. Thank you very much for coming. Some of you toward the back, you might want to move forward because the side screens work. The big front one is missing a light bulb. So this is our 12th Disparities Forum. And I know there's a lot of folks that are signed in through Zoom. We have four distinguished speakers, and I will allow them to introduce themselves so I don't get their titles wrong or mispronounce their names. And this is a very interesting project that we've done, and we've had a lot of very interesting speakers of all aspects of disparities. Dr. Joyner, there he is. So I'm going to let Dr. Joyner just say hello and welcome to LSUA, our distinguished partner, and then we will move on with the speakers. So you have to stand here if you want to. There's what the camera sees.
Well, good morning. I'm Dr. Haywood Joyner. I'm Dean of the College of Health and Human Services here at LSUA. Our College of Health and Human Services consists of the Department of Allied Health, the School of Education, and the School of Nursing. So we are very, very interested in the work that you guys do and everything that you do for our community. And we're delighted to host you again on our campus on behalf of our Chancellor, Dr. Paul Carell, who could not be with us this morning, our Provost, Dr. John Rowan. I'd like to take this opportunity to welcome each of you to campus. If there's anything that we can do, you can please contact us and we'll make sure that we will take care of those things that you may need today. My apologies that the bulb is out and you're not going to see the big screen. That means I'm going to have to sit on the front row because I can't see that far back. But we're delighted to have you with us, and thank you so much for the excellent and outstanding work that you do for the healthcare of our community and our region. Thank you and welcome to LSUA.
So we try and keep this train on the schedule here, and we're going to start with Dr. Cynthia Thomas, and she will tell us her role and then give her talk about disparities in education.
Good morning. How's everyone? I am Dr. Cynthia Thomas. I'm a psychology professor here at LSUA. I've been at LSUA for about 13 years now. And prior to coming here, I am Louisiana born and raised, but I did leave and do a stint in Maryland and worked in Washington, D.C. So I was a counselor there, worked in the schools, worked in the jail. So quite a bit of experience in looking at disparities. And so this morning I was asked to talk to you guys about disparities in education. And I had this fantastic presentation prepared for you guys. And I don't know what happened when we went to open it this morning. It is not there, it's not available to us. So I know the information. I've been working with this for a while. So we're just going to talk about what we would have talked about anyway, if that's okay with you guys. So in order for us to understand the disparities in education, we really have to look at the relationship between disparities, education, and privilege. And that's really at the crux of when we look at education in the US, that's really at the crux, this privilege that exists that is not made available to everybody. When we look more specifically at Louisiana, actually one of my first slide was a graphic of looking at the disparities in who attends public schools. And so when we look at Louisiana, Louisiana has the second highest population of its students attending private school. So about 16.8% of the students in Louisiana attend private schools. if we would have seen the next graphic, you would have noticed that for Louisiana, about 20% of the population has a college degree. So when we think about it, that's not saying that everybody that goes to public schools ends up with a college degree, but absolutely quite a bit of those students who go to private schools do go to college. Most of those children do end up with a college degree. Does that make sense? When we look at poverty rates in Louisiana, what we know is that the poverty rate is about 19.5, 19% for Louisiana. But when we look at people who have bachelor's degrees, the poverty rate for that group of people is only 5%. And so again, when we're talking about disparities in education, we have to look and see, we have to consider privilege, because you have a certain section of the population who's not even using the public school system, a certain segment of the population who recognizes that if I have the money to send my child somewhere else and pull them out of this system, then this is the choice that I'm going to take. When we look at across the country at who's getting scholarships, who's going to college, a lot of those scholarships are awarded to private school students, more so than to public school students. So that is something that we need to keep in mind. I also wanted, it's important that we also consider how those disparities persist. Right? So we have a school system. So we know that people who have resources, they tend to pull their students out of the public school system. And I'm not making a judgment about that. I have 2 kids. My kids go to private school, if I'm being honest. So I'm not really making a judgment about that. What I am acknowledging is that I see that there are major issues in Louisiana in the school system. And so let's figure out where we can kind of address some of these issues and people make the best decision for their children. So really, I'm really not knocking that, but I do want to highlight that people are faced with tough choices. And when they have the resources, they tend to make different choices for their kids. But when we look at some of the things that exist to uphold these disparities, we have to consider the structure. And you always hear about there's disparities in the structure. The rules create these imbalances. Well, the rules do create these imbalances. And sometimes we're so embedded and so ingrained in these rules and following these rules that are set that we don't realize that the rules create an imbalance based on income and based on race. And so one example of those rules is if you're in a public school system in some of the districts, the parishes in Louisiana, 2 kids get into a fight, right? A fist fight, not unusual for teenage boys, especially. They get into a fist fight, no weapons are used. They have this fight, they go to the office. The officer on campus then takes them to jail. That is the policy of the school district. But let's think again, who's in that school? Is everybody equally in that school? No, the children with resources, and to a large extent, that's the white students, are in private schools. So you set up a standard where if you fight, if you're in a public school, you go to jail. So now these kids have a record, right? A criminal record. So when there's a fight at certain other parishes, usually parishes that have a lower minority rate, but in certain other parishes, when you look at their private schools, they don't have that same rule. So a fight 2 miles down the road at the private school, those kids get into a fight, they go to the office, they go home. They don't have a criminal record. Does that make sense? So there definitely is a connection between education, law enforcement, the criminal justice systems, where you can see all these disparities take shape. But when you have rules that exist where if everybody fights, everybody goes to jail, well, it seems like it's fair and it's across the board, but inherently there is a there is that something, and there's always that something that disadvantages certain groups, and usually those certain groups are people of colors. When we look at some of the other structures that persist in society that continues with these disproportionate rates, these disproportionate outcomes in education, we also have to consider funding, right? Funding of school comes from tax dollars. So you have, and actually I can pull up the video. Can I pull up the video?
Sure.
Okay. I can pull up the video quickly.
Yeah. When you get the video up, just share the screen on your Zoom.
So I found this video that really speaks to this disproportionality that exists. And so what this video talks about, I'm sorry,
You want to make sure you share your sound too.
okay,
Go back to Zoom.
okay, I'm back at Zoom. And
Go to, you can go to new share, that's fine. Just go to share.
new share,
Click on share sound up top.
okay,
Yes, sorry.
thank you.
For academic
So,
subjects.
when we look at structures that exist, when we think about public school, how it differs from private school is that we don't have to pay a lot of money to attend for our children. And so our children get resources that are publicly funded, so funded through our tax dollars. And so when you look at the differences that exist in schools and how that funding structure works and where it comes from and how we get there in the first place. And so if we look for a minute, if we think about our own communities, you can think about Alexandria or wherever you're from, because this happens across America. So I'm confident that you can think of a place where this happens wherever you hail from. There's a community, there's an area in town that is the good neighborhood, right? And then you start noticing minorities moving into the good neighborhood, right? They work hard, they save their money, they move into the good neighborhood. And then you notice white people moving out of the new neighborhood and they're building a new community. This community has been planned. And so they are now located somewhere else. But they don't just move to this new community. They also take with them the things that support equity in that community. So now the grocery store is going to leave this community and go to the new community. The cleaners will leave this community and go to the new community. All the services that make the community worth living in, they're now leaving this community and going to the other side of town. Well, this formerly the good neighborhood where everybody wanted to be, their sidewalks were always maintained. They're not being maintained anymore. The streets that were always maintained, those streets are not being maintained anymore. The businesses that left and went to the new good neighborhood, well, their tax dollars are not there anymore. So now, and this isn't happenstance, there's planning committees. And so each town has planning committees. They don't just decide, let's go over here. This is planned years in advance, right? And if you're not on that planning committee, you don't have access to that information. You don't know what neighborhoods you should be moving in. You don't know what's coming down the pipe, but they know. They know 10 years in advance where the resources will be. So now you're in this neighborhood and your community isn't generating income. Your community isn't generating taxes anymore. Does that make sense? And so it's not just moving into the neighborhood that's bringing down the value of the neighborhood, is what the residents do when they leave the neighborhood and take everything with them and leave empty vacant buildings. And so then you get to a situation like this.
My name is Cedric Forte. I'm a junior at Heritage High School, 420.
Hang on.
25.
My name is Jackson Langbort. I'm 18-year-old.
You can
I'm a
hear it
senior
on
at
the
McLean High
Zoom.
School. For academic subjects,
wonder-
I'm in advanced placement literature,
English,
advanced placement U.S. government,
biology,
Where's
and
the
comparative government,
IT guys? Do we know how to
advanced placement music
unmute the
theory,
speakers in the
health.
room?
geosystems for science,
and algebra.
men's chorus,
Let's see.
That says media.
Do we know?
Yeah, on the right. Where it. Oh, okay. I got it.
My name is Cedric Forte. I'm a junior at Heritage High School, 425.
my name is Jackson Langbort. I'm 18-year-old and I'm a senior at McLean High School. For academic subjects, I'm in advanced placement literature,
English,
advanced placement U.S. government,
biology,
and comparative government,
art,
advanced placement music theory,
health,
geosystems for science,
and algebra.
men's chorus,
What's it?
leadership, and technical theater. So I drive and I get here half an hour before school starts every day, just for the fun of it. Trying to park here, if you come in at normal time, is really awful. You end up parking like half a mile away.
A lot of students who go to a school all the way across town have to catch 2 and 3 buses in the subway just to get to school. And I think that, you know, if we have to travel that far just to get education, then we should be able to travel for free.
The kids here are motivated in just about everything. They're motivated to even learn, which is scary to hear for a high school kid. They're motivated to succeed in sports, extracurriculars, anything.
I think they've lost the will to learn. A lot of them. They just like don't find school interesting no more because they don't have the power to do anything. And they say so in the classrooms.
This is our auditorium and theater. We have lights, standard light sound. It's not particularly high tech, but we have a nice system.
Here, go to the metal detector. Like they use this to try to, you know, keep school safe, but obviously it doesn't work because like even when someone walks through and it beeps, like they don't even search them or anything. They just say, okay, walk back through, empty your pockets. That's all they do.
This is our new studio. It's one of 3 high schools in the county who has it. Hey, orchestra, can you start playing? Okay. It's all kids. It's all run. It's all performed. It's all produced by kids.
Well, one thing that these walls, like they really need to be repainted because the graffiti, as you can see here, they tried to repaint it, but it doesn't blend in. You can actually tell they just like really just gave up on repainting the walls. So every teacher in this school buys their own school supplies. And it's actually very sad because like the school system should have money to, you know, provide for those school supplies for students, but they don't. And the teachers have to come out of their paychecks just to, you know, be able to support their students.
That's our observatory. It's a giant dome with a telescope, and you could see the entire sky from there. If every school in the country can be like McLean, I think it's really going to increase standard of living, just going to make things a lot better.
Obviously, it's not fair. I mean, we have not even half of what they have. I mean, we're all students. Why shouldn't we receive the things that they have? I mean, we're all trying to learn. We all want to grow up to be something, so why shouldn't we receive the same advantages they have? I don't understand that.
And so several things stood out to me when I first saw this video. When we're looking at disparities, just imagine the outcome, the output from these different schools, not even considering, well, consider the classes because they started with the classes. You had one school with AP class and you had algebra, biology. And so what is one student prepared for when they graduate versus what is the other student prepared for? Does that make sense? And so again, there are some environmental issues. There are some, and I will acknowledge that there are some things that people can do differently, but there are systemic issues that support the these imbalances, because again, you have people going to public school. If we just focus on public schools, you have two very different outcomes because you have two very different systems that you're passing these students through. Does that make sense? And so where one is willing to learn, one has an environment where they're set up to learn, the other one is they're going to learn, but they're not going to learn the same thing. And so when we look at these disparities, we also have to look at who's in the classroom, who's teaching in the classroom. When we look at one major disparity that you always hear is that Black boys, they are disciplined more harsh, they're suspended more. About 30% of IEPs are done on Black kids. And so that means that they have been referred for some type of special education services. And so we have to keep that in mind. There was a research study done in 2019, and what it shows is that for Black boys, if they have one Black teacher, that increases the likelihood that they will go to college by 13%. If they have two Black teachers, that increases the likelihood that they will go to college by 32%. When we think about the school systems, even in minority schools and largely African-American schools, most of the teachers are white, middle-class people. And so there's a very huge disconnect between who's providing care and education for those students. These kids are more likely to enroll in college just by having two Black teachers, but often we don't see them in the classrooms. The reason for this is, yes, it provides a role model, but it also, there is a very distinct difference in expectations. Those teachers expect those Black students to do, and so they hold them to a higher standards, and those students rise to the teacher's expectation. There is also less a likelihood that those students will be seen as a disruption to the class, and when their behavior is not perfect, they're not seen as aggressive or disruptive. They talk to them, calm them down. They don't send them to the office. And so we do have to think, if we're thinking about these disparities and what do we do and where do we go from here, we do have to look at what's happening in the classroom and what's those structural things in society that supports that. And so if you're in the classroom, what can you do differently? Perhaps what you can do is actually talk to the students in a meaningful way. Don't say, did you get into trouble over the weekend? Because what does that imply? That they're a problematic child. Ask them instead, well, what did you do this weekend? Did you do X, Y, and Z? Actually talk and listen. Share something about yourself. Share your own story so that they can get to know you. And if you're a white person in a classroom full of minority children, ask yourself, when was the last time I spent time with minorities where I wasn't in charge? Right? If I can only step into a room with minorities and be around minorities is only when I'm the teacher, when I'm in charge of the classroom, then that's problematic because you're guiding these people and you're not really getting to know the students. You're not getting to know their culture. You're not getting to know the environment that they come from. So at some point, you have to make the choice to choose to understand the students that you're working with. Without this, it's very, very likely that these disparities will persist. All right.
Always a pleasure. Thank you. All right, so how do we get out of this? Unshare.
Yeah.
New share.
Click stop share.
Stop sharing.
Stop share. There we go. Whoa, stop share. All right. Yes, this is a big issue, and it's a big issue in for medicine too, because the medical schools are scrambling because we have 3.5% Black doctors in Louisiana, and Blacks are 30% of the population. And that is horrendous. And by the time they're scrambling to recruit students and retain students and mentor them and all that, this starts in preschool. You know, you don't wait until, you know, they're going to medical school to try and catch up and do all that. So anyway, so we're moving right along with economics, and Dr. Randall DuPont is up here. He will explain what he does, and we will keep things on track. Thank you, Dr. DuPont.
Thank you, Dr. Holcomb. I have got a PowerPoint. Is it working? I don't think we do. Let's see. We still need to close this out. Would you close this out? I want to open the PowerPoint. Let's go to the desktop. This is share one. This is fine here. Right. Can you share that?
This one right here.
No, this one. And then here.
Go back and share that.
Did it not share one?
There it goes.
Okay.
Share it online. Okay, fantastic. Good morning, everyone. Dr. Holcomb, thank you very much for the invite to be here today. I'm Dr. Randall DuPont. I am the Dean of the College of Business here at LSUA. I'm a native of Louisiana, and like Cynthia, moved away for about 29 years and came back home. So it's good to be here and to be back. I am also the publisher of the Central Louisiana Economic Dashboard. I don't know if you've seen that or not. We've been publishing it pretty close to 3 years now, and it's on data about Central Louisiana's economy and in particular jobs. So if you've ever read that dashboard, I'm very data driven. So I apologize in advance if I've got too much data in here and not enough graphics. So, but I'll try to explain. I think we've got, and I focus my data on Central Louisiana to a large degree. What I want to talk about is wealth disparities, and we'll start with that. The data for wealth disparities is really more national and state data. It was very difficult, and actually I could not find wealth disparity data for Central Louisiana and the parishes that are within Region 6 here. But I did find a good deal of data on income disparities. Of course, that leads to wealth disparities. Okay, so we'll take a look at those, and we'll take a look at those, and we'll also look at how education impacts those income disparities as well as wealth. So let's take a look at those. And we're going to start with this is a concentration of wealth in the United States. And if you look at this, it's talking about the median. Now, you know the difference between median and mean. Median being the 50th percentile level, where half the people are above that level and half are below that level. And here's the data on net worth for US and for Louisiana. Also, keep in mind, what is net worth? You might have a home that's worth $200,000, but you owe $180,000 on that home. Okay, you don't have $200,000 of net worth. You've got $20,000. Okay, so you've got to subtract your liabilities from your assets to get net worth. So here in the US and Louisiana, you'll see net worth is $140,000. Louisiana's running $81,000. What I'll be pointing out to you are some geographic disparities as well. Okay, if we exclude homeowner equity, and you'll see it's down to 46 and 22,000. If we look at checking accounts and other things, quite low in some cases for Louisiana. One of the things that I liked when I looked at this data was look at retirement accounts, the IRAs and 401ks. Louisiana is pretty much holding its own here. Now let's look at the median. And when we look at the median, what we'll see is that we've got a little bit better scenario here, okay, for Louisiana. We've got 491,000 in the US, Louisiana at 327, excluding home equity. You'll see it falls, of course, for both of them. And equity in the home, you'll see those numbers here. Look at the IRA and 401ks. Louisiana is actually doing better than the rest of the nation in those terms. So that's good news. Now, let's break this down on the basis of race. This, once again, this is national, and we're looking at, first of all, median, 50 percentile level. Total is 140,000, we said earlier. When you look at white alone, 178, white alone non-Hispanic, 217, Black alone, 18, Asian, 264, and Hispanic, 39,000. Now, this is where 50% are above or below this level. Let's bring into it the average. And you'll see for every category, of course, it goes up, but disparities still exist. Okay, so you'll see the total for the nation goes from 140 to 491 in net worth. White alone, 542, 602, white non-Hispanic, 162 for Black alone, Asian 679, Hispanic 231. So this is, once again, this is on a national level. If we look at this on an educational attainment level, and as much as possible, I mean, education is my life. It's what we're all about here. I always want to know if education makes a difference in your life. Yes. Put the mic closer. Okay. So this is wealth concentration in the U.S. median net worth by educational attainment. So if we look at high school, this is 50% of those who have no high school diploma. Okay. Let's see what happened here. We've got something showing up. Okay, we got it. If no high school diploma, $4,600. Okay, high school graduate only as far as their net worth educational level, 41,000. Some college, 71. Look at bachelor, 233, and graduate, okay, 459. Let's take a look at the same data again. And this time we're looking at the mean, the average. And as you can see, it's significantly higher on the average. So education plays a role, and a significant role, in whether or not someone is going to have a net worth. And of course, all of these disparities still exist, whether it's the mean or the median.
Up a little bit as well.
Okay.
Camera, the speakers on the camera.
The speakers on the camera. Okay. I will do my best. I published the economic dashboard, as I was saying. Let me show you some of the data that I published. How have we done? We're on about third year of doing this. How have we done since COVID? And this is going back to January of 2020. You'll see back then we had around 61,000 employed in the Alexandria metro area, which only includes Rapides and Grant Parish. And look, we had a sizable dip in employment. And then we came back later that year and was able to exceed our COVID level, the pre-COVID level. About a year later, we also exceeded it again. And if you look here from December of 21 all the way till about July of 22, we, let's close this out. We had record highs in post-COVID employment level. So that was about 6 new highs in about 8 months. So employment wise, we have done really well compared to a lot of other areas in Louisiana. Let's take a look at the unemployment rate for metro areas. This too presents the picture. And that picture shows basically that Alexandria has an unemployment rate, the lowest in the state for a metro area, 2.5%. It has been that way ever since COVID started. It was not that way before COVID. So it's interesting how it's changed. A few more things on employment. This is employment for the entire central Louisiana area. You'll see the parishes that are being covered here in Region 6 of Voiles, Catahoula, Concordia, and so forth. They're all quite low in employment. And the region as a whole is around 3.0% unemployment rate. The state's at 2.9%. This is one of the first months in 3 years that I've seen the state basically get below this region. This region has had really very just impressive employment numbers. And once again, employment per job opening. How many jobs do we have out there? We have 6,000. Look here at the top, 6,300 jobs. This is in the month. This is job postings in the month of November. We had 1,600 unemployed. That comes out to a ratio of 0.26 unemployed persons per opening. In other words, let's flip that around. It comes out to 4 openings, 4 job postings for every unemployed person. And you can see that too is one of the best in the state. Now, the difficulty is that it's difficult for employers to hire folks in those circumstances. Let's look at the distribution of labor here in Region 6. Now, Region 6 for the labor market department here in Louisiana is just one parish off from Region 6 for the medical. Vernon is not in this data, so that's the only difference. But you'll see that about 2/3 of all of the employment in this area is going to be here in Rapides. And of course, you've got to bring Grant into it for the metro area. So sizable portion here. Let's look at the distribution. In other words, where are those jobs here in Central Louisiana in Region 6? And you will see that they're going to be found in retail trade. They'll be found in educational services. They'll be found healthcare and social assistance. And lastly, in accommodation and food services. These are 4 major areas in which you will find upwards of 54% of all the jobs in this labor market are in these 4 areas. Why do I point this out? I want you to look at the weekly wages. Look at the weekly wages for retail, educational services, and accommodation services. $601 per week, $741, $349. Okay. The average for this entire region is $929, and only healthcare and social assistance is above that. So we've got 54% of our population that is in very low wage jobs. And then compare this with the rest of the other 46%, and you'll see those numbers are much higher. Okay. So we have disparity as well in jobs and when people are being paid for the jobs they're doing. How has the job market looked in the last 3 years since pre-COVID to post-COVID? And you will see we lost 2.8% of the jobs in our region. The only area that was positive was Catahoula Parish, but everywhere else, Wells lost 7.8, Wynn 7.6. We here in Rapides lost 1.6. So we've lost the number of jobs in the area. Let's take a look at earnings. And this is earnings geographically. Now I will tell you just Region 6 has some of the lowest earnings in the state. I think the only region that might be a little bit lower, and that's going to be Monroe, that area. But here are the earnings by parish, from LaSalle as high as 42,000 all the way to Concordia at 28, with Rapides at 35,000. Then we start breaking it down into earnings by gender and by parish. And you will see here that regions like LaSalle, and this is broken down to male and female, male being in blue, female in orange, and you will see wide disparity in LaSalle and Wynn and Vernon. And this disparity decreases all the way until about Rapides, and this is about the lowest disparity between the two, and then it kind of accelerates again. I'll show you the disparity in a separate chart, and you can see it easier. So the average disparity for this entire region is 68% between male and female, with Rapides having the highest percentage of female earnings to male earnings in 2021, with LaSalle having some of the lowest and Wynn and others. So Rapides has the highest. Let's take a look at earnings by gender, by education. So this is looking at high school education and how does it impact earnings. So you'll look at LaSalle here. Once again, male 59 compared to 16, wide disparity between these two. And this is with a high school education. And then we look at it, you can see sometimes the disparity gets closer and other times it continues to stay wide. One of the narrows is right here, once again, in Rapides. So I've taken that data and I said, let's look at the disparity here. Here's the disparity between men. In other words, the percentage of female earnings compared to male earnings with a high school education in those parishes. And you will see Rapides is the highest at 69% and 68% for Grant, LaSalle, and other who are 28 and 30%. But the average at the high school level, so if the male and the female have both a high school degree, the average that a female is making here in these 8 parishes is only 52% of what a male is working. Let's continue. looking at this. This is what happens if there's a bachelor's degree by the participants, those studied. And you will see, once again, we've got some disparities. Let me scroll to this one. Now, with a bachelor's degree, okay, comparing male and females with a bachelor's degree, what is the percentage that female have of earnings to males with a bachelor's degree? And you will see that average is 77%. So it is higher. And I don't think that surprises anyone here. So, but it's good to see the numbers, and you can see the difference that education is making. Let's look at income distribution. This is the percentage of the population by income and race here in Rapides. And the way this chart works, the first bar here is under 10,000. And then from the second bar up until about the middle, it's about $5,000 increments. Then once you get to this bar, you're at 50,000 and above. These are $10,000 increments, and then this is 75. This is the percent of the population by income, by race in Rapides, and this is for the Black population. What you'll see is a heavy concentration here in these lower income areas, and then, but still a decline. You see a slight movement up, but then also a decline as you start approaching the 75 to 100,000 and above, and so forth. Overall, there is a downward slope to this. Let's compare this with the white population. Here's the white population. You'll see not as high in the lower incomes, trending up here. Once you pass 45,000, you see a very sharp rise upward. This is the 75 to 100,000 range, and then a significant level in the 100,000 and above. So you can see the disparities by income, by race. Let's put these two together, and you can see the comparison or the disparity even more so. Okay, where you've got one trending down and then the other one trending up. And of course, there are structural issues and systematic issues that affect that, as Dr. Thomas was talking about. Let's look at poverty in this region, how we're doing on time. Okay, we're good. Poverty in the region, we have 25, this is the percent of the population that is below the poverty line. Concordia having the highest, Calhoun and Avoyelles. Notice what's in common with all three of these. They're all along the Mississippi River. They're sort of in the Delta region. As we get further inland, what you see is a lower level of poverty. When we look at poverty by education, okay, and I've broken this into two groups, the red being those with a high school education or less, no high school, and the black column being those with some college, not necessarily a degree, but all the way up to a degree. So it's some college or a full degree. And you can see those with higher levels of education, regardless of what parish they're in, certainly are at a lower percentage of those below the poverty line in those parishes. Then I broke it down into male and female by poverty line. And you'll see here, once again, we've got some parishes that have greater disparities. Females across the board in all the parishes have a much higher percentage that are above the poverty line than males. And there are some areas that are closer to 50-50, but still all of them are above. The percent of males below the poverty line by education. So when we look at males below it, you will see that males have, the females have a pretty high percentage here. And so this is once again, this is high school and below, and then some college or a full degree. So once again, it makes a difference for males. As you'll see, it makes a difference for females. Education has a role, okay, in taking people out of poverty. So let's look at the same data. This is females, okay, below the poverty line. And once again, red is those high school education or no high school, and black being those in the some college or a full college degree. Now, what you will notice, though, it's a little more pronounced depending on which one you look at. Look at those last two charts together, one on top of the other, and what you'll see is that males who have in 7 of these 8 cases here, males who have a high school education or less have a higher likelihood of being below the poverty line. And what you'll see here at the bottom is that females, even though they have a college degree, okay, have a higher likelihood of being below the poverty line compared to males who also have a college degree. And so, and this final one here, this is one I took out and said, let's just limit this to 4-year degrees only. Okay, so this is a look at who is below or above the poverty line, just looking at 4-year degrees or no 4-year degrees. And what you will see here is that with a 4-year degree, this is both male and female. It is quite low. As I said earlier, it makes a huge difference in whether someone is below poverty. And this is looking at females, slightly higher, of course, than the general population we just looked at. And so it's higher for them as well. Annual earnings. So we talked about degrees making a difference, but here's the point I want to make out with this one. We got a couple of minutes. Not all degrees pay the same. Some degrees pay more than others. Okay, this is LSUA. This is in percentiles, 25 percentile, 50 percentile, and 75 percentile. You're going to be in those higher percentiles if you've worked longer and you've got more expertise. Okay, so let's look at the different degrees. So on the left-hand side is going to be the LSUA degrees, basically for all instruction. Let's compare it with education, and you will see education degrees pay a little bit less than what the general degrees pay. I mean, the combined total is. Let's look at English and language and literature. Once again, that's lower. So people going into some of these fields are going to have less income potential. Let's look at biology and biomedical. Look how much higher this field is. Okay, significantly higher, especially in the 75 percentile range. But still, they'll start off higher as well. Here's business management and related. You'll see those are slightly higher on the lower on the entry level, slightly higher than the 50% and higher on the 75 percentile. And then here's psychology and communications, and you'll see that they're slightly lower than overall of all the degrees. So my point here is basically degrees do make a difference, okay, but not all degrees are the same and have the same employment potential. I thank you. Appreciate it.
So, you say like, what's this got to do with the Office of Public Health? Screen has stopped sharing. I guess it's okay. What's this have to do with public health and health in general? Well, the 3 determinants of health are education, income, and social status. And if you look at who is getting even a high school degree, there's 10% of white people who don't get a degree, a high school degree. It's up to 17 to 20% in Blacks. And all of that has all these repercussions all the way down, including how long they live ultimately. So that was fascinating and a little depressing. You might mention that all those parishes that have these consistent problems were those that had over 70% enslaved persons in 1860. So the past is not past. The past is not dead. It's not even past. So we're moving along to something else here, substance use navigators. And we have Melissa Steinbeck, and she will take this over here and introduce yourself, who you are.
Get my PowerPoint up. All right, there we go. All right, we're good to go.
Speak up, because the mic's on the
Okay.
camera.
All right, thanks, Dr. Holcomb, for having me, and excited to be here in Region 6. I'm Melissa Steinbach. I'm with the Office of Public Health. I'm the opioid outreach coordinator, and I have on the call, who probably will just pipe in if she needs to, our regional medical director, Dr. Lacey Kavanaugh. And we're here to really talk about, so we definitely have seen from our previous speakers, all of the disparities. So we're here to talk about a particular population that faces disparities and problems with access to care, and that's people who use drugs and people who are struggling with addiction. So we want to tell you about some interventions that we put into place. But before I get to the Louisiana Bridge program, which we're really, really excited about, and have had some great partners in our region that I'm going to tell you about that have implemented this program in our emergency departments. I really want to spend a little time talking about our data and how we got here and why we chose this intervention. All right, do we have a clicker?
You have to just use the mouse and click. Yeah, or the space bar.
There we go. Okay, so just a bit about my role, and it'll kind of set up where I'm going to take you with the data. So my job in Region 5 is to raise awareness about the opioid crisis. I spend a lot of time collecting and analyzing our region-specific data, closely with the coroner's office, with Acadian Ambulance, and really look at who is it that we're losing? Why is our overdose mortality so high? And then where can we intervene? So my job today is to tell you about our intervention that's at the hospital level. So what I'm going to start with is our data. I'm going to tell you what our region-specific data looks like for overdose mortality. Talk about how we use these data to drive the interventions to reduce overdose mortality, and then specifically tell you about our Louisiana Bridge program. So first, this is our overdose mortality that comes from our amazing partner, the coroner's office. We work closely with Charlie Hunter, who's the chief investigator. And really, when we started this work in our region, this is where we began. We began at his office, sitting at his table, talking about, so who are we losing and what our data look like? So you can see our trends follow nationwide trends. Our mortality rates have been going up, up, up. You can see a big jump we had between 2020 and 2021. Our biggest bar is in 2021. So we lost 92% more people in 2021 to overdose than we did in 2020. So we had a huge jump in 2021. In talking with the coroner's office, they just said we're underwater. We've never seen anything like this. We consider this an emergency. And then we at Office of Public Health also consider this a public health emergency. And so really in Region 5, that's how we're responding to this. About 2 weeks ago, we got data for 2022, and I'm just excited to be here and have good news. Our overdose mortality rates went down by 30%. We're thrilled with this. And we do believe it has a lot to do with several interventions that we put in place in Region 5. One of it, which is related to the one I'm going to tell you about, but it's widespread Narcan distribution. So we've done a lot of Narcan, targeted Narcan distribution through different partners. So that's a whole other presentation, but I did want to mention that. So when we looked at these data, they helped us really look at a couple of different things and so that we could drive our interventions. So these are looking specifically at 2022. Looks really similar to our 2021 data with a couple of caveats. The average age of the people we're losing is 35. So we're losing young people that should not be dying. What we also know is that every one of these deaths are preventable. Okay, so that's why we're really focused on putting interventions into place that'll reduce this rate. The majority, and we really gleaned this from our coroner's data, right? The majority of the people we were losing, they're people who have struggled with substance use disorder for a long time, and they've been unable to connect to care. So we're really focused on what are we're missing something. We need an intervention where we can help connect people to care. So we were able to see that with those data. I'm gonna move on to our toxicology results. These also were very important in driving our strategy. So these trends follow nationwide trends, but locally we know that most of our deaths are driven by the fentanyl in the drug supply. So this 76% from 2022 were caused by fentanyl. That number has only gone up since 2021. So we know what's killing our people. It's in the illicit drug supply, and it's the fentanyl that's really the primary driver. Other thing of note from our toxicology data is that there's a lot of polysubstance use. So when people die, there's a lot of stuff on board. But the biggest takeaway for us is that meth is in everything in our drug supply. So our not meth, fentanyl is in everything. So in our meth, for example, the majority of our people who had meth in their system that died had fentanyl in their system, and that's what drove the overdose death. The people who died that had cocaine in their system also had fentanyl in their system. So that's telling us our drug supply is highly contaminated. It's the press pills. We know in our local area, we're finding things like Xanax, we're finding Adderall, Oxys that have been pressed with fentanyl. So it's those press pills, but it's also the cocaine, the meth, and other drugs as well. Just a quick nod to our Acadian ambulance partners. We were able to use these data. So we sat down with them as well to look at what was going on in our region. And we're able to use these data for a couple of different things. So these are overdose calls, non-fatal overdose calls where they responded with Narcan. So if you respond with Narcan and you revive somebody, that means you've taken an opioid, probably fentanyl. Okay, so we know these are people struggling likely with opioid use disorder. So what we did with our ambulance data is, one is we used the geographic hotspot data to identify neighborhoods that had high rates of overdose, and our street outreach, Southwest Louisiana Do No Harm, an amazing outreach program, could really target those areas for Narcan distribution. Second thing is we're able to look at these data and see where is Acadian taking the overdose cases? Which hospitals in our region are the primary receivers of overdose? So that helped us drive our intervention at the hospital level. Okay, so we knew from looking at our data where we needed to start if we wanted to intervene at the hospital level. So I'm going to backtrack just a little bit. So I don't know, you guys may all be familiar with this, and I'm not going to spend a whole lot of time, but I really do like this graph because it shows kind of how we've had different waves in explaining our overdose epidemic. So in the very beginning, what caused our epidemic is different than what's causing it now. So in the very beginning, it's pretty highly publicized. We know that pharmaceuticals were really pushing out prescribed opioids, right? And so there was a big push to prescribe. We had this false idea that opioids were not addictive. They're totally safe. We've got to treat pain. So that's kind of what started our drive into this. And then when doctors realized this isn't right, we got to pull this back, we did. We started rolling back prescribing, right? So heroin entered the picture, and that's what was really driving our overdose deaths. So we've shifted completely away from that, and the fentanyl, the illicit fentanyl, is really what's driving our overdose deaths today. So the reason I want to tell you about that is, one, I think it's good to have that base understanding of what's going on, and then that really affects how we look at our interventions. So what we do know is when we did start curbing that the prescribing rates, and doctors were very good about pulling back. So you can see that's the bottom of the graph, opioid prescriptions. So we've been good at cutting that back, but look what happened to overdose deaths. They skyrocketed. So that tells me something's not working. You know, our interventions are not working. If you just looked at the bottom part of that graph, we could pat ourselves on the back and say, great, we curbed prescriptions. But when you mirror it to what's going on, you realize something's not working and we need to do something else. So this is, I'm starting to get in some of our work with California Bridge, which I'll tell you about in a minute, but this is a slide from their deck and their presentation that I really like because it really frames where we are. We are really worst case scenario when we're looking at overdose deaths right now. We had this massive sustained exposure of the population to opioids. It's really what the graph just showed. We pulled that back, abrupt regulation, but we didn't think about treating addiction and how we created this population that's very dependent upon opioids. So organized crime was real quick to come in and fill that gap with heroin and fentanyl. So what we do know, and what that graph two before showed, is what we're doing is not working. And so we really need to shift gears on how we're reaching out to people that are struggling with addiction in order to save lives. And coupled with that, we are in emergency mode. So we got to figure out quickly, how can we reduce these deaths? This is a quote that comes from California Bridge that I always loved. You do the best you can until you know better. And then when you know better, you do better. So that's where we are. So let's do better. So now to the intervention. Sorry, I had to set that up. It's just, that's kind of how we got here. So we realized the hospital and the ED is really a perfect intervention place, right? Because you have somebody who's just overdosed. And we know what it looked like 2 years ago in our hospitals when you go in with an overdose. You were released as soon as you were medically stabilized. How fast can we get you out of here? Okay, so we knew that needed to change. So we started exploring different options. And I right now want to give a big shout out to Imperial Calcasieu Human Service Authority, because they are the ones that really got this program going. And it's really been a partnership between Office of Public Health and MCAL to implement in our region with such success. So I want to tell you what the program looks like. And why, a little bit about why the ED is a critical partner. What we do know, and this is the disparities, certainly relevant for the disparities conversation we're having here today, is that 10% of Americans with substance use disorder, only 10% receive links to treatment and links to care. So that's just a small portion of people who need care that receive care. Of that tiny 10%, only a small fraction of those actually receive care and linkage to evidence-based standard of care for opioid use disorder, medication-assisted treatment. So we got to do better at linking people to evidence-based care and to care we know works. So if you work in this field, you know why it's failing and why it's not working. We can long laundry list, and this is just some of them. Our population here in Louisiana, especially our rural population, has long drives to treatment. It's not easy to access care. So transportation is a huge barrier. There are long waits often if you're ready to go to treatment. Again, if you work in this work, your window's about this big. And if you say, hang on, I'll have a spot in 2 weeks, your window's closed. And you're not going to link that person to treatment. So the long waits are just failing the people that we're trying to reach. There's always a list. Okay, I'll put you on the list. There's insurance authorization, all kinds of links to, if you're going to be on buprenorphine, you're going to have to do it perfectly, and you're going to have to come to counseling, and all these stipulations we put on it. So just a lot of barriers, in addition to the stigma that people who use drugs face when they're trying to access care, right? So stigma is huge, and it's a huge part of the program that I'm going to tell you about. So just to kind of lay the foundation for why the ED, and a nod to Dr. Kavanaugh, I'm about to get into these slides that you can feel free to jump in on. So this graph here shows us the mortality rate post-ED discharge when you go in with an overdose. So when you come into an ED with an overdose, you have a 5% risk of dying in the first year. That's huge. 5% mortality in the first year after you have gone into the ED with an overdose. We're talking about, this is an emergency. This is an emergency. You do need to be treated and linked to care. You can see that huge spike on day 2. So 20% of the people in this group don't make it past day 2 after overdose discharge. So it's really astounding and just kind of pointing to the fact that this is an emergency. This slide shows the differences in mortality rates. So when somebody comes into the ER with a STEMI, there's a 7% mortality rate. And so I've heard Dr. Kavanaugh, Dr. Holcomb, you pipe in too, talk about this enough. I think I can tell you the point of this. That's big. And when you're an ER doc, you spend a lot of time thinking, how am I going to reduce this mortality rate? We have standards of care and ways we're going to treat you when you come in with STEMI. 5.5 for overdose mortality is really high. We have standard of care. We have evidence-based medicine that works, but we're not practicing it in the ED. So this program is really focused on, let's start treating overdose as the emergency it is and linking people to evidence-based care right here at the ER. And just an aside, that 5.5%, those are young people dying. The 7.3, that's a population that is a good deal older. So the age disparity there is alarming. So the model, we found first of all, never recreate the wheel if it's already been invented. The California Bridge Model of Care is a program that's based out of California. It started grassroots, like in 1 or 2 hospitals, and it is now expanded to the entire state. So they have the whole package free on their website, and they have access to all their founders to help support hospitals who want to implement this program. So there are 3 pillars sort of to this program. First is that access. Every ER should provide rapid evidence-based treatment when an overdose comes in, okay? The second pillar is in the ED, we're going to create this culture of care and respect. So we're trying to reduce the stigma. A lot of my doctors wear these, you can talk to me about drugs. They have signage that says, you're welcome to ask any of our staff about linkages to treatment or services. Really key. The third pillar is our substance use navigator who connects people to care. So this is an amazing team with lived experience. They are called every overdose that comes into the ER. We now have space, so they're actually sitting in the ER for regular hours, and they go in and they navigate and advocate for this patient. They provide family supports and connection to care. So I'll tell you more about that. I'm going to skip these are our medical slides and how buprenorphine works. So I just am going to tell you in plain language, the evidence is there that when we link people to care with OUD, when we link people to Suboxone treatment, you are much, much more likely to have that person stay in care a year later. We know it works, and we know we're failing in terms of linking to effective care, okay? So I'm not going to do the medical slides. So this is a study out of Yale that California Bridge presented to us in support of their work. So when we link people to do the rapid evidence-based treatment to buprenorphine right there in the ER. So for those who don't know what it does, it treats withdrawal and cravings. If you have somebody that comes in with an overdose, and typically those are people who are long-term users, they're not going to feel good at all. They're going to feel like they're dying. You treat them with Suboxone, within about 10 or 20 minutes, they're feeling a lot better. They can actually talk to our navigators and really see a possibility of connecting to care and feeling better, okay? So in this particular study, the people that were connected to buprenorphine, 78% were still connected to care a month later. So they were still going to their providers a month later. So there is this retention and care. And it was really the key piece was the Suboxone or the buprenorphine, okay? Initiation in the ED. This is another kind of support for that. You can see that the percent of people in care in 30 days, like I just talked to, there's retention. But then you also see in the second or the right-hand side that use goes down. So people who are connected with medication-assisted treatment, their use of illicit street drugs also goes down, which is the goal, right? And just a quick note, we do still have people that we're placing in detox, but what we do know, the research is telling us, detox, it doesn't last. So if it's detox alone with no coupling with medication-assisted treatment for opioid use disorder, you're at much greater risk of dying if we let you out of detox and don't treat you with buprenorphine than you are if you have some continued care, medication-assisted treatment after detox. So this is just one of the resources. California Bridge has everything you can imagine to start the program. And the whole goal is to make access to buprenorphine much easier than access to illicit street drugs, okay? So these are our substance use navigators. This is one of our signs at Lake Charles Memorial Hospital is where our initial start was for this program. They've been amazing partners, and you really have to have that champion within the ER that embraces this, and Dr. John Gray has been that for us. But the whole role of the substance use navigator is to meet patients where they are with no judgment and no stigma, and not to go in and say, you go into treatment, where do you want to go? It's to say, what can we do to help you? Here are your options. Let me advocate for what standard of care for you. And this is really kind of the model of what it looks like. A patient comes in, they're identified with SUD, which an overdose usually checks that box. Our navigator is called, meets with them. And then we spent a lot of time in this program before we went in. Our navigators spent a lot of time talking with providers in the community so that we knew we had places. So MCAL has MAP providers. That's our human service agency. We spoke with their providers. They set up time so that we could link our patients to care within 3 days. So, which is critical, because you can't say, come in 2 weeks. Here, we're going to treat you with Suboxone, come in 3 weeks. No. So we have special spots. Our Sun navigator calls Dr. Jones and says, hey, I got somebody from the ED. She says, send them in 2 days or in a day. And the ED docs are either treating with bupe and we're immediately linking to treatment, or they're giving them a 3-day bridge prescription so that they can make it to their next appointment, okay? These are actually 2 of our navigators, and they are rock stars. That's Rome and Rachel. And they share time between 3 of our hospitals that are participating in this program. They've lived experience, they've been there, done that, and they're amazing. This just kind of outlines what these guys do. They really, truly are the role model for change in the ED. We don't really go in and hold a bunch of stigma and bias trainings, because they're actually doing it. So they lead by example, and they are true heroes. The doctors just beam when they walk in the room, and it's just leading by example, and it really has changed the culture of care in the ED. So our guys, our Sun navigators, provide support to the ED team. They have regular check-ins with their physician champion. They spend a lot of time in our community making sure that we know what the resources are. And then they build that trust with the patients and the families and provide the support. So success in this kind of program looks like it's all patient driven. So there's that authentic patient connection, rapid start of medication, simple process for filling prescriptions and treatment follow-up. This program, it's not perfect. So I'm the cheerleader for the program, but we are working out barriers every day. And what we do is we sit down. I sit down with my navigators, our MCAL partners sit down, Dr. Kavanaugh and our public health partners sit down, our street outreach and harm reduction team. We sit down on really, I would say at least a weekly basis, if not more, and troubleshoot the problems that come up, because there are problems that come up, okay? And this is what the whole model looks like. Again, you really have to have that clinic champion. You have to have somebody from the inside that drives it. or it's not going to be nearly as successful. And then the navigator and the patient. So these are just a few of our numbers. We've linked 222 patients with a sign this year at Lake Charles Memorial Hospital. So we've met with 222 patients. Over 70% were linked to some level of care in the community. All patients leave with harm reduction information. All patients leave with links to our harm reduction team. And one of the biggest wins for us is that, and this alone to me is life-changing. It's affected our mortality rate. 95% of these patients have left the ER with Narcan in hand. So we know they're at high risk of mortality when they walk out of our door. They now have Narcan, their family has Narcan, so that if they need to reverse an overdose, they can do it. And we truly feel like this has had, profound effects on our overdose mortality rates. So Dr. Kavanaugh, if you have anything you want to add in, she might have had to hop off.
Yeah, fantastic.
Okay, thank you.
Wonderful work. Well, we were greatly inspired by this, the work of in Region 5. Region 5, for people who don't know, that's Lake Charles area. So they initiated this, and it's really a role model it's a best practice for every public health region. And so we worked with our Office of Behavioral Health here to get this going. And like they mentioned, we're going to work out all the kinks of all this. I'm not sure we've got the buprenorphine prescription in the ER part all worked out yet, but this really makes a difference. And so it's a proven intervention, and we are very anxious and happy that this has been initiated in our region as well. Both hospitals here are working with us. So we have Rapides Regional and Christus Cabrini. They're both on board. They both have their sons, their substance use navigators. And so we're very grateful to the leadership of Dr. Kavanaugh and her team. You hear that, Dr. Kavanaugh, out there?
I did. Thank you.
Okay. So as in many things, the best ideas often come from the field. All right, so we'll move right along.
Dominique from our.
Where's Dominique? There he is. Okay, we have one of our sons here, and could you stand up and
Gonna give a little update.
oh, okay, getting about the update. Okay, you have about 5 minutes for a little update.
We don't have to.
Yeah, that's all right.
They put me on the thing, so I don't know. I was just
You can
sitting
say
out
hello to
there.
the folks.
Hey, how y'all doing? I'm Dominique. I'm with the Central Louisiana Human Service District, and as Dr. Holcomb told y'all, we're with the mobile crisis, and we have the sons, and we're placing people in the emergency room, like they're doing down in Lake Charles. We've been having some great success. We are in Cabrini and Rapides. At Cabrini, we started in November. We've probably seen about, it was kind of slow at Cabrini, probably seen about 20 people, but we got about 12 of those into inpatient treatment, and about 8 of them connected with the peers, the navigators we have on the team. And about 2 of them, after when they got up, they just got out the hospital. We do have that happen. But we're really excited because we started at Rapides on last Monday. And since last Monday, I think we've had 13 people, and we've gotten 10 of those people actually placed into treatment to continue on their journey in recovery. And, it's just a great thing because, like, a lot of people don't deal with substance use, but if you ever had a heartbreak or something like that, you don't call or you don't go to your friend who's never been through a heartbreak. So when someone comes up from an overdose and they have someone who's actually lived that experience, they're more receptive and they're in a vulnerable state, and they're willing to talk to that person and to get connected to a different type of care, you know, maybe a therapist or treatment or whatever it may be. So we're excited. And that's it. Thank y'all.
All right, well, we'll move right along to something we always talk about, which is sexually transmitted infections. And so we have Elizabeth McClung, and she will tell us about that. This is unfortunately an area where we have lots of disparities, black-white ratios, and it's a very difficult subject to talk about. And I'm absolutely the wrong messenger because I'm an old white guy, and that's not people. So you want to have people that also live this experience talking about it. We have Kenneth Nash is here, and where is Kenneth? Raise your hand up there. He's he's one of our disease intervention specialists here, and please let us fill us in.
Just 1 second. We're gonna forget about that. Oh. All right, so hi, everybody. My name is Elizabeth Lindsay. I know I was presented as Elizabeth McClung. That's my maiden name. But my name is Elizabeth Lindsay. I'm the perinatal surveillance supervisor for SHIP, which is the Louisiana STI and HIV hepatitis program. So we're going to be covering HIV, syphilis, and Hep C today in Alexandria and at the state level, and really trying to understand impacted populations. There's a lot of data in this presentation, so I'm going to talk fairly fast. But if there are any questions, please come and find me. I'm more than happy to speak on this further. We'll start by speaking about the state of HIV in Louisiana. This graph depicts new HIV diagnoses across the state from 2012 to 2021. From 2014 to 2020, Louisiana experienced a staggered decline in HIV diagnoses with a marked decrease in 2020, largely due to COVID. Louisiana also ranked 4th in the nation in 2020 for number of diagnoses. This decline was unfortunately not observed in 2021 as 901 new diagnoses were reported, an increase of 25%. Yep, go ahead.
Is that a number or percentage? We rated 4th in the nation in the number or the percentage?
Are you talking about the number of diagnoses?
Right.
So we had a staggered decline in just the number of diagnoses, not the rate. So just, kind of looking at raw numbers from there. But from, for 2021, we had a 901 new diagnoses were reported, increase of about 25%. Preliminary data has us at about 746 new diagnoses for 2022, but that number is expected to change. From here, we need to consider the impacts of COVID-19 on HIV diagnoses, prevention, and treatment within Louisiana. As we just stated, there were an increase of new diagnoses in 2021. When we look to linkage to care, 75% of patients in 2021 were linked to care within 30 days of diagnoses. This was a 3% increase compared to 2020. 66% of persons living with HIV in Louisiana, so despite of when they got diagnosed, so everybody living with HIV, were virally suppressed, less than 200 copies. This was on par with what was seen in 2020, and that's a typo, so I apologize for that. And it's important to state that a person who has reached viral suppression cannot pass HIV onto a sex partner. So let's dig into Region 6 specifically. In 2021, Region 6 had the 7th highest number of new HIV diagnoses in Louisiana and the 6th highest HIV diagnosis rate among the 9 public health regions. This graph depicts HIV and AIDS diagnoses. From 2012 to 2021 for persons living in Region 6, we can see that there was an increase in 2018 in diagnoses for the region, unlike the decline seen at the state level. This increase coincided with the syphilis outbreak within the region. As we know, those two feed into each other. Diagnoses declined to average levels in 2019 and 2020. We saw a stabilization of HIV diagnoses in 2021, but we did see an increase in new AIDS diagnoses within the region. All right. Among the 44 new diagnoses within Region 6, an overwhelming number of them, about 73%, were among persons of color, specifically Black and Hispanic persons. When we look at gender, the majority of diagnoses were among males, 80%, followed by females at 18% and transgender females at 4%. Almost half of new diagnoses, 46%, occurred among those between ages of 30 to 39. When we look at those most affected by HIVs, when we dig even deeper into those subgroups, we can clearly see the disparity. Black and Hispanic gay and bisexual men make up over half of the new diagnoses in Region 6. For comparison, Black people make up 27% of the region's population, with Hispanic people comprising 4.1% of the region's residents. There's a huge disparity on who is living here and who is affected by these diagnoses. This slide breaks out new HIV diagnoses by parish. Half of HIV diagnoses in Region 6 occurred among residents of Rapides Parish, followed by those residing in Vernon and LaSalle parishes. So when we think about HIV diagnoses, the main thing we want to think about is getting someone diagnosed and getting them into care, because we want them to achieve viral suppression as soon as possible. As stated previously, because we know that that's the key to curbing new infections. The HIV care continuum allows us to visualize the key indicators of this care. In Region 6, there were 1,000 persons living with HIV in 2021, of which 71% were engaged in HIV care in the same year, meaning they had a CD4 or a viral load lab in the calendar year. 57% of them were retained in care, meaning they had 2 or more tests more than 90 days apart. When looking at viral suppression, 63% of them were virally suppressed, again, below 200 copies. And this is 4% less than what we see at the state average, so a little bit lower. And then among persons living with HIV engaged in care, 88% were virally suppressed, and this is on par with what we saw with the state average. From this graph, we can see that the Alexandria region has made steady progress over the past 5 years at increasing viral suppression among persons living with HIV and persons living with HIV in care. From 2017 to 2021, the percentage of persons living with HIV who were virally suppressed increased from 55 to 63%. For the same time period, the persons living with HIV who were in care and virally suppressed increased from 79% to 89%. So there's a really great increase that we see across this timeline. And while these gains are encouraging and promising to see, it's important to note that this progress is not equitable by race. When we break this out between Black and white persons, we can see 66% of Black persons living with HIV in Region 6 who were virally suppressed, as compared to 71% of their white counterparts. When we look at viral suppression among persons living with HIV in care, 86% of Black persons in care achieve viral suppression, as compared to 94% of their white counterparts. So again, that clear disparity. We are making strides and progress in ending the epidemic across the state and here in Region 6. But as we just saw, a deeper analysis is needed in order to make sure that those gains are equitable and not just gains for a few. We will now move on to syphilis. Sorry, hang on. In 2020, Louisiana ranked 12th in the nation for primary and secondary syphilis rates. Primary and secondary syphilis cases have remained around 700 cases per year, but there was a significant increase, about 19% in 2021, with 842 cases. We've had about 821 reported so far, but that is expected to change. When we look to Region 6, we can see that the area has been experiencing an increase of primary and secondary syphilis since 2016, as we can see in this graph below. Since 2018, the Alexandria region has had the highest rate of primary and secondary syphilis of all 9 public health regions in Louisiana. For 2021, the region had a total of 160 cases that were reported, which is almost 5 times higher than what we saw in 2017. And again, this breaks out primary and secondary syphilis diagnoses in Region 6 by parish, similar to what we saw for HIV. The majority of diagnoses occurred among residents of Rapides Parish, and this was followed by those who resided in Grant Parish. When we dig deeper, we find that over half of primary and secondary syphilis diagnoses in Region 6 for this year, or for 2021, were among white people. This is different from what we saw at the state level, which saw that Black men made up the majority of diagnoses. For gender, males comprise 63% of diagnoses, followed up by women at 36%. This is slightly higher than what we've seen at a state level at 27%. When we break down diagnoses by age, 40% of the diagnoses occurred among 20 to 29-year-olds. And then this was closely followed by those between 30 to 39 years of age. So as we just saw, increases in early syphilis among women yields increases in congenital syphilis. So for those of you who are not familiar with congenital syphilis cases occur when a mom who has been diagnosed with syphilis and untreated passes along that infection to her infant. It's important to state that congenital syphilis is preventable and can be eliminated through early and repeated maternal testing, along with treatment initiated at least 30 days before delivery. For pregnant women, that is benzathine penicillin. In Louisiana, we have a third trimester testing law, which requires opt-out syphilis and HIV testing for all pregnant women at their first prenatal care visit, at the first prenatal care visit in their third trimester, and at delivery if testing and status is not noted. But we always highly recommend testing at delivery just to make sure that mom's titers have not changed since her last test. When we look at Louisiana overall, we saw our highest case count in 2021 at 110 cases. We usually average at about 65. About 229 pregnant moms were diagnosed with syphilis in that same year. We had a total of 107 moms and 110 infants that were linked to a congenital syphilis case. Unfortunately, we had 5 infant deaths that were documented, so syphilitic stillbirths and infant deaths that were shortly after delivery. Among these cases, 65% occurred among Black women. 31% of mothers were between 25 to 29 years of age at delivery. 1 in every 532 births were born with congenital syphilis in Louisiana for 2021. And as our latest CDC report, Louisiana had the 7th highest congenital syphilis case rate in the nation. But that's just as of our rate for 2020. When we look to Region 6 specifically, when we look to the Alexandria region, we can see that, again, we've seen a steady increase of congenital syphilis since 2018. So the same thing that we saw for early syphilis as well. Alexandria region had the highest case count out of all 9 public health regions for 2021, a total of 22 cases. 45% of these cases occurred among residents of Rapides Parish, followed by Aboyles. For 2022, 10 cases have been reported so far, but this is expected to change. Of the 22 pregnant mothers linked to a 2021 CS case within Region 6, an equal amount occurred among Black and white women. This is strikingly different from what we've observed at the state level, where the majority of cases occurred among Black women. For Region 6, 50% of mothers were between 20 to 29 years of age at delivery. 1 out of every 177 births in Alexandria region were born with congenital syphilis in 2021. The Alexandria region also had the highest case rate for congenital syphilis among all the public. So like we do with HIV, we also look at different points of a pregnancy to analyze missed opportunities in order to prevent future congenital syphilis cases. We first looked at timely prenatal care, which is defined as prenatal care initiated at least 60 days before delivery. For Region 6, we can see that 68% of moms linked to congenital syphilis case met this marker, which is comparatively lower than what we saw at a state level at 73%. Out of those moms, 93% of them received an initial syphilis test, so looking at that first test during pregnancy, that occurred at least 45 days before delivery, which again is slightly lower than what we saw at a state level, 96%. One of the biggest disparities that we see is with timely prenatal care with recommended testing, so that repeated testing in the 3rd trimester. In Alexandria region, only 50% of moms linked to a CS case met this milestone, with comparison to 56% at a state level. The absence of third trimester testing is the biggest missed opportunity that we see statewide and what we also see for the Alexandria region. Last but not least, we will now speak on chronic hepatitis C. Louisiana experiences a significant morbidity from Hep C. Alongside that, our residents are at a heightened risk of acquiring hepatitis C. We have the third highest number of liver and bile duct cancers in the nation and have the fourth highest rate in deaths for them as well. More than 110 Louisiana residents are at risk of acquiring Hep C statewide. Over 9,800 persons who are enrolled in Medicaid are also in need of treatment. 474 of Region 6's residents are included in this group. With this in mind, we also need to state that Louisiana has launched a statewide Hep C elimination program back in 2019 that aims to treat all Medicaid enrollees persons who are incarcerated. So this graph, no, it's fine. This graph depicts the number of new chronic Hep C diagnoses over the past 10 years at both the state and regional level. The large increase in reports of chronic Hep C diagnoses that we see in 2014 were driven by new effective treatments becoming available, resulting in more testing and more surveillance. Additional capacity allowed for these tests to also be reported and captured by the state health department. And again, with the rising influence of the opioid epidemic. So that all of that kind of happened at the same time. For 2021, a total of 4,732 diagnoses were seen at the state level. And despite making up 6.4% of the state's population, Region 6 saw 354 total diagnoses, which comes out to 7.5% of the total diagnoses. So again, that disparity. Among the new diagnoses, when we look at sex by birth, males comprise the majority of diagnoses at 71%, with females making up 29%. White people made up the majority of diagnoses at 67%, and people 30 to 39 years of age had the highest proportion of diagnoses at 25%. This again breaks out the diagnoses by parish. Across them in Region 6, 64% of new diagnoses resided in either Rapides or Grant parishes. With all of those numbers in mind, especially for Hep C, it's important to stress that we cannot get somebody linked to care if we do not know that they are positive. We need more testing, especially for Region 6. As we saw in 2022, which is our most current reporting year for testing, 9.8% of people 18 years of age or older were screened in Region 6. Out of them, about 5% tested positive. When we look at that at the state level, 10.5% of people 18 years of age or older were screened in Louisiana, so a little bit comparatively higher. And then we also saw a higher positivity rate. More testing is needed across all groups, but especially males, American Indian, Alaska Native people, Black people, and white people. Many thanks to my surveillance colleagues for putting all of this data together. This is a huge group effort each year for us to clean up this data. And thank you guys so much for your time, and thank you guys so much for the hard work you guys do every day to serve the patients that need it.
Well, we do have a couple of our community partners here. Is that Dr. Porter in the background? Yeah. So we have the CD4 clinic, Tulane CD4 clinic, who does important work with all of this, HIV and hepatitis C. And I saw class is right here. And so they do a lot of work too with us. This is a big problem. And you saw that the black-white ratios here are worse here. I mean, they're not worse. There's more white people involved in this than Black people compared to the state level. And this is congenital syphilis and syphilis in general. And when they look at the cases that come out of this, about 50% of the women who are either have drug addiction issues or sex for money. So there are some really drivers. And then COVID just did a number on everything. So it is an ongoing effort. And I just hated it that Region 6 was the star of congenital syphilis. And we really tried to work on this as much as we possibly can. So we have plenty of time for questions. So I think Dr. DuPont had to go out, but now you have a few minutes for questions. Is this just too depressing for you all? Yes, it's a very fascinating subject. Yes.
I've got one for the presenter who did on education. I'm sorry, I didn't get a chance to note down your name.
Yeah.
But I guess the question I have is like,
You
I
can
know
come up.
that when it comes, like funding for public schools is always a big issue. It's like the way it's like, I mean, even the example with two schools, like the Maryland district had $90,000 median income, and like the Baltimore area had 40,000. So like, what are the solutions for if you were in front of a legislator saying, hey, this is how you should allocate taxes for schools? Like, what would be like the prescription for that?
So making funding more equitable, because remember we talked about, it's almost like the decision makers create a problem and then penalize the constituents for a problem. And I'm sorry, for the people on line, he asks, how can we resolve this issue where people in higher income areas receive more funding than people in lower income areas? And so make it more equitable. If you're creating this problem by moving the resources, the tax generating resources out of the area, you can't then say, oh, well, then your community doesn't generate enough taxes, so we're not going to give you any money for your schools. You're looking at the people who are not the decision makers and penalizing them for something that they had no control over. So I've never understood why cities have done this to begin with. There's usually enough money so that there can be resources on both sides of town. So we can start there. So there can be 2 grocery stores, there can be 2 Walmarts, there can be 2 hubs in towns. If there's enough money to grow, then there's enough money to keep this other side flourishing as well. You don't have to cut it off at the neck, because essentially what you're doing is bottlenecking it. You cut it off at a certain point. And so that would be a starter. But perhaps instead of looking at, okay, how much money does this community generate, let's just look at how many students are in this school. What's needed in this city? I mean, when you look at the, I know when we did the business thing, when you look at what's needed, when you looked at jobs, there were a lot of jobs, but the jobs that paid were in healthcare. So let's look at what the community needs. Healthcare, people who degree in healthcare, and then let's pour money that speaks to that so that the town can become, they can take care of themselves, so to speak, and we can put people in higher paying jobs. It's one thing to have a lot of jobs, but you want a lot of jobs that pay well. So you really have to get people prepared for that.
A lot has to do with the MFP formula for our state and how funding goes to school districts and how that formula is calculated for school district and for student. And it's different in each state. We have a rather complicated system called the MFP system in our state for how dollars are allocated to public schools.
Right. And so the comment on the floor is about the MFP system in the way that dollars are allocated. But again, remember when I spoke about systems that support this division and that allows it to persist? That's not set in stone. We see that it doesn't work. Well, we see maybe it is working the way that it's intended, but it isn't working in a way that is equitable. So it takes a couple of meetings to change it. Let's change it and do something else.
Takes legislative action.
Right, to change it. And so the question becomes, why aren't they changing it? Are they really getting the results that they hoped for? And that allows that disproportionality to persist.
There's just a comment about that every system is perfectly designed to produce the results it produces.
Yeah.
So we have made choices, and Louisiana is 50th out of 50 in its health outcomes, and it's been that way since 1990, when this whole system of state. So there's a lot of things that can be done. Any other questions? Because I will say that we have these 3 parishes. We have Avoyelles, Catahoula, and Concordia, these river parishes, and this runs all the way up on both sides of the Mississippi and up into Arkansas, where you had significant enslaved populations. And all of those parishes have poor health outcomes now, and they're all poor. And so the tax base is less, and the schools. So many of those schools in that area receive a disproportionately high percentage of federal funding. And that's a good thing. So the federal government says, you know, you need money, you get more money. But if you look at whether they get enough money and funding adequacy, all of those schools in that same area are also not adequate. So it's quite a picture out there. Yes. Yes, if you're out there on Zoom and you have a question, just put it in the chat. We have at least 3 of the speakers here, and we have a lot of expertise in the room too, of folks who are deal with this. Any other questions? That was a ton of material. You've got to have some questions here. Or maybe it's all perfectly obvious. Ms. Leger, you're an expert in Avoyelles Parish. You have any questions or comments?
I'm just thinking of some of these things that need to come to our rural parish who has such these bad looking numbers. But meetings like this is so incredible because they bring all these resources to us. I guess I'm just sitting here thinking of how people who are involved in the transmitted diseases and how if women are impacted. I'm just sitting here thinking, how do you think the reversal of Roe is going to possibly impact these numbers?
Oh, she really wants me to get in trouble. Okay, that was a question about the change, reversal of Roe and Roe versus Wade and all that, and the Dobbs decision and so forth. So the Office of Public Health, you know, as a public servant, we execute state policy, and you know, we don't have an independent policy in this. How this is going to impact, I think, will become more obvious with time. But I will say that almost all of these health disparities are they're poverty and low education and all the racial things that get involved in all this are terrain for unequal results. And it is no chance, or it's not really by chance, that the Black person will live 4 years less than a white person in Louisiana. There's no genetic reason. So any policies that will be disadvantageous to people of color or anybody who's in poverty, that's essentially inequitable.
Oh, I hope everybody saw the snapshot of the disparities for women. That is just so huge and glaring.
Yes, well, I mean, I thought it was very interesting that Dr. DuPont brought all that out too, because it's not just racial deals. And so it's also men disparities too. So, I mean, this area can be a model. We have a lot of people of goodwill. We have an educational institution, LSUA here, who is interested, and the public health as such, the core of public health now is supposed to be equity. And so I know this gets on some people's nerves, but that you have to view all of your actions in terms of its equity.
We have a question from the chat. As a community organization, how do I connect people who have used Narcan to rapid treatment? And do you have any statistics on folks who have used Narcan at home or in private situations as opposed to the emergency department?
Well, Narcan, you can get Narcan through any public health unit. You can just go and get some, and it requires no prescription through a pharmacy. So it's readily available. And as Mrs. Steinbach said, that everybody that leaves the ER who has seen a son leaves with Narcan. I mean, if they don't, then they really have to be, there's something's happened. But so it's easy. Narcan actually has virtually no downsides. It's in itself, it's not addictive. The problem is that you require more Narcan now because fentanyl is so omnipresent and so destructive, and their doses are so high that sometimes people have to receive 2 or 3 or 4 doses to really overcome the effect of intoxication. That's a problem.
Now, I think Alex can probably speak to statistics on people using it at home.
Yeah, you can, let me just bring him up here. Alex, yeah, he doesn't want to be a public speaker. But he has been, he and class have been working with us very closely with harm reduction, which includes, some needle issues and that sort of thing, and Narcan distribution. So why don't you talk about your deal?
Before you start, how much Narcan can you get as a public health? If it takes that many doses to reverse, how many doses can you get?
Well, you can get as many as you need. And so, some people may require 1, 2, or 3, doses to take home. So, I mean, we usually give 1, and we're trying to get it in the schools as well, because this happens at schools. I mean, it's unbelievable, but it's happening in schools. So there's no restriction on it now.
That's good.
All right, so my name is Alex Stallings, and I am the program manager for our syringe service program here in Region 6. It's called Fresh Works. It is a program of CLASS, which is a community-based organization that's been around for a long time, serving people living with HIV here in Region 6 with various different social services. We have case management, linkage to medical care, all that kind of stuff. But with our Fresh Works program, what we do is anyone who identifies as a person who uses drugs can come into our program. They can see one of our, harm reduction sort of specialists or experts. I got 2 of my team members over there as well, Jarvis Fontaine and Daniela Price. So we are an excellent team. We have really expanded the amount of people that we're able to serve through that program, and especially with adding a couple of new team members on. We have over 350 individuals who have enrolled in our program since its inception. I don't have exact numbers for you right this second, because the last time I would have looked at this would have probably been sometime in August, probably for Mr. Kenneth Nash up there presenting some updates for him. So, but what I can say is that since the program's inception, we have distributed probably 3,000 doses of Narcan. We have received reports of reversed overdose in excess of 300 reversed overdoses. And most of those individuals reside in Rapides Parish or kind of in the surrounding areas, because some of the other issues to accessing our program have sort of come out here today, right? Poverty levels and people's lack of access to transportation mean that they can't really get to our agency. And due to the city ordinance that allows us to operate this program sort of excludes us from being able to do any of our not any of our harm reduction services, but specifically our syringe services aren't allowed to operate outside of Alexandria. So anyone that, even if they live outside of Alexandria, anyone that needs to access our harm reduction services or our syringe services can come into our agency, enroll in our program, to gain access to safe injection supplies, gain access to syringe disposal, and probably just as important as any of that, gain access to Narcan or other forms of naloxone. So you have intramuscular or injectable naloxone, which some people prefer due to sort of the speed of efficacy that exists there. You tend to see a quicker reversal of that overdose when an intramuscular form of naloxone is used. But for the ease of use, I think a lot of people like that nasal Narcan, which is just a nasal spray that pretty much anyone can administer. So with that said, I encourage everyone who cares about the health of their community to start carrying Narcan, because you never know when you'll need it. Just a couple of weeks ago, a good friend of mine called me and he said, "Hey, do you have any Narcan?" I wasn't at work, but I tend to keep some at my house anyways. And so I was able to go take that Narcan to that individual and help his family with the situation that they were dealing with. So you never know when it's going to come up. It may not be somebody that, directly, or something like that, but you never know when it's going to be a situation where Narcan could be of use to someone around you, whether it's a family member, a friend, a neighbor, whoever. So yeah, I'll kind of leave it there. Just encourage people to carry Narcan. If you know people who need our services, please refer them to our agency. The agency is CLASS and the program is called Fresh Works. So.
And I just want to add on first a big shout out to Alex and his team, because I know you guys are saving lives every day. And Alex, we've been on some Zooms together, and just as my harm reduction team in Region 5, just doing tremendous work. And I can assure you that our team was responsible for that mortality bar coming down. They had about 156 reversals reported. And you know that number is super low because numbers reported back, they're just, hey, call me if you can and tell me if you actually use this Narcan. So those are really low. But just one more thing I wanted to add on the intent of the Louisiana Bridge program is rapid 24/7 access to care. So the idea is, and it's not perfect yet, we're working on it, but the idea is that if you want to start medication assisted treatment, you can walk to the ED and say, hey, I need help and access to care. And we've actually had patients linked to care who walk up to the ED. Our son meets them there. Dr. Gray writes them a buprenorphine prescription and we link them to care. So that's the idea behind that program. But we do also have people who want to link to care that call our harm reduction team and say, hey, where can I go? And our harm reduction team links them to care too. So
someone mentioned about the Narcan portal there. You want to address that?
The Narcan
Portal.
portal.
Yeah. Well, there's a Narcan portal. They are allowing some people to access. I don't know what the approval process is. For you to be able to order your own. Yeah, and they can apply that order your own Narcan.
Okay.
I can say just a word. I think it's still, there is going to be a portal that Office of Behavioral Health and Office of Public Health are working together to set up so that agencies across the state can actually apply to the portal and receive Narcan. But I think it's still in the early stages and they're working. So I don't have a whole lot of information on that. It's in the pilot phase right now. So they've tested some organizational ordering. But it should expand access. So we're really excited about that.
There is another question from the chat. How is child welfare at Refuge School Board addressing public and private school disparities when a student is suspended from a public school for a fight?
Ooh, I think you'd have to ask Mr. Powell about that one. Is there anybody from the school board? Okay, now as mentioned here, I mean, do you know about how?
They're not. So
Well, come on.
So the question is, how is child welfare at Refuge School Board addressing public and private school disparities when a student is suspended from a public school for a fight?
they aren't addressing that. It really isn't. As a matter of fact, the state doesn't have a set standard. So some parishes send their students to jail when there's a fight. Some parishes don't. They leave it up to the parish. And as far as the parish stance on it, they have no jurisdiction over the school system, over the private schools, so they don't worry about it. They just do what they want to do. And their data does show that sending the children to jail does not reduce the likelihood that there's a fight on the campus. And so, again, if the outcome is to least restrictive, educate the children, they're not meeting that outcome because it has no effect of reducing fights on campus.
Okay, well, thank you. Okay, well, we're at 11 o'clock. So anybody have any last comments? Dr. Porter, do you have anything you have to say? Ah.
I think they have a prep program as well. And want the community to be aware of that.
Yeah. So the comment was that we do have a PrEP program, and though these are for people who are HIV negative, they're not positive, and they have a normal creatinine, their kidney function is normal, and they may have high-risk behaviors, and it is a preventative treatment. It's very easy, and it's actually quite effective. All right, it is 11 o'clock. I would like to thank everybody how many people joined in? 82. So we had 82 people call in, and I appreciate everybody coming despite rain and all that. And I'm sorry we didn't have a light bulb, but maybe next year. So thank you very much. And if you have individual questions for anybody, just feel free. And this gives you plenty of time for the people going to the luncheon to go over to the luncheon. Thank you very much.